very, not the big picture, but kind of the small picture, but in a way it's a big picture for those individual families. Because for that mom and that family, this baby is the big picture. So I'm going to concentrate on that. And so what we're going to talk about, I don't like the term peri-viable because that's already a negative connotation. So I'm going to talk about outcomes at the extreme limits of viability for infants born at 22 to 23 weeks gestation, managed with a positive, proactive approach. And for example, what I'm showing here is a set of 22 and 1/7 week twins. They were born early because of twin-twin transfusion. I put a lot of times I'll put the percentiles because people think that every baby born at Iowa is Hardy farm stock and all these 22-weekers are LGA, and they're actually 24-weekers that we misdated. But mom knows the exact dates on these girls because they had actually laser surgery in Cincinnati. There's a picture of them at age 4, and then there's a picture of them at age 4 and 10 months. So nothing to disclose. So the objectives is I'm going to focus on single center survival for infants born at 22 to 23 weeks gestation compared to baseline. And it's single center because management strategies that you use both before the baby's even born, so prenatally, and strategies in the delivery room and strategies for the next 5 months greatly impacts outcome. And I find getting the big picture really doesn't help you to really improve. It gives you something to compare to, but doesn't help you to improve. I'm going to talk about global concepts utilizing a proactive. And proactive is so critical. I quote Benjamin Franklin, an ounce of prevention is worth a pound of cure. The same thing. You don't wait till the baby's in overwhelming septic shock to decide maybe we should start antibiotics. You need to act at a very subtle change. It's got to be standardized, which is what quality improvement's about. And it also has to be balanced. And I know we were talking about balance earlier, and you can't have things equally balanced. So what I mean by balanced is really what takes priority. Is brain protection more important or is lung protection? You've got to figure it out, and I think the answer is obvious. I'm going to talk about short-term morbidity, as well as 2-year outcomes for peri-viable infants born at 22 to 23 weeks. And then the thing, when I realized this was a joint conference, I will review some obstetrical interventions at 22 weeks used by my colleagues. So when we talk about survival of inborn, I guess here I did peri-viable, infants born at 22 to 24 weeks with a proactive approach, I use cumulative data because year to year there's not that many 22-weekers. And you can be fooled because you might have 1 year with 25% survival and then you have another year with 100% survival, which is reality. Well, reality is the greatest numbers that you can generate. So I do cumulatively 17 years here. So at 22 weeks or survival for 17 years is 60% survival, and that's 79 live-born infants. Now, the live-born, some of the neonatologists will say, well, if you don't do active therapy, obviously you don't survive. So if we look at survival of admissions, it was 64% survival at 22 weeks, which is 73 admissions with 47 survivors. At 23 weeks, it's 77% survival for 124 babies, and 85% survival at 24 weeks of 127 admissions. Now, I put these twin girls on because a lot of people also say that Iowa can't date pregnancies. Every state in the US can, every country in the world can, but I'm told no one in Iowa dates pregnancies correctly. That's why you have survivors. So I complain a lot, and then the mom says, Dr. Klein, you're really, really old. I'm like, what do you mean? Well, you don't remember on the history, my kids were IVF. I'm like, oh yeah, I forgot, I'm old. And so this was a twin IVF pregnancy. The one who was born first was 22 and 3/7, 485 grams, 39th percentile. Her sister was happy to get rid of the first one, and she stayed in another 4 days. So she made it to 23 and 0, and almost was LGA. She was 630 with 87th percentile, and there's the girls at 15 months. Interestingly, survival is improving for premature infants born at 22 weeks gestation. Well, for a long period of time, people thought this was a threshold that would never be broken because Vaughan data from the US showed survival basically hovered between 6 and 8%. But suddenly something changed in 2015, and survival started climbing up to as high as 17% of all liveborns, so tripled survival, and the number of centers offering active therapy doubled. Now, if we look at the most recent data, I can't tell you how many centers are offering active therapy, but I will say, if you look at all liveborns in the VON network, for level 3, 4 centers, it's up to 27%, which, as you can see, is almost 4 times higher than it was 10 years earlier. Now, what started happening in 2015, sort of 3 things happened. One, there was a paper published in the New England Journal of Medicine from the NIH Neonatal Research Network. And that paper did comment that there were some surviving 22-weekers. Now, when that happened, the New York Times, and this is the New England Journal of Medicine, the New York Times got a hold of this and contacted us, because a lot of the survivors in that network were from Iowa, and put it on the front page of the New York Times, one of our patients. And then at the same time, organizations started contacting Iowa and say, well, what are you doing differently that's allowing 22-week babies to survive? And that started bending that curve upward. Now, you can see our practices are kind of valid for the whole population. And you can see there's 22 weeks, and that's again from 06 to 2021. And I'm comparing it to, at least in this one, the 2021 VON data of level 3, 4 centers. And you can see at every gestation, survival is higher, and obviously mortality is much, much lower. Now, is this unique to Iowa? And it is not. Because what you can see here is it's basically there are other major centers worldwide that can have survival at 22 weeks. So it's not a fixed threshold. So you can see Iowa is around 60% in this graph. VON in this graph was in the low 20s. The orange was a paper written in 2022 from the Neonatal Research Network. And that paper's created a lot of controversy, because if you look at survival of all liveborns in that paper, not all centers offer active therapy. It's only 11%, which is that white arrow. But if you look at survival of places that offer therapy, active treatment of 22 weekers is 30%. So that paper, depending how you want to interpret it, you can say, well, this is pointless, only 11% survival. But again, if you don't offer therapy, survival is 0. Dark blue is Cologne, Germany. Light blue is the Japanese Research Network. Green is Sweden. We all do much better at 23 weeks, of course. Now, Cologne, Germany, I want to talk briefly about. This is one of the concerns that obstetricians have, is something called cherry picking. In Cologne, Germany, they want to put their efforts into babies they know will survive. And being German, they're very strict. And so, you know, and the survival is 38% of all liveborn, but 60% of all ones that they offer therapy to. And now it's up to close to 70, because they only offer therapy at 22 weeks if you have 2 doses of betamethasone and you get a C-section. That's what they do. And if you don't want to do that, you're not going to get treatment. That's their concept. Japan has had a couple of papers. This one was 81% survival at 22 weeks. Another recent one was also 81% at 22 weeks. Just to show you it's not unique to Japan. A lot of places like to poo-poo Japan, because they tend to be, say it's unique to their genetics or something. But certainly at Iowa, I can show you years. 2016 was 77% survival, 10 out of 13. 2021 was 78% survival, 7 out of 9. Now, I would not tolerate any of our fellows saying, oh, I was there in 2021, so I'm going to tell parents 78% survival. Like, no, you're not. You will be gone. You need to stay with, 60%. You don't have that ability to predict that accurately. So what is a proactive approach? So to me, it's a philosophical expectation that infants born at 22 weeks gestation will survive and thrive. This is really critical, and this is something that Sweden talks about and it's published on, because when they try to have other centers in different countries replicate what they do and give them a very good handout, multiple handouts, many pages long, if the people doing it don't think it's going to work, it will fail. And that always happens. And they've written very eloquently about the culture has to change. If the nurses don't believe, the nurse practitioners don't believe, the residents don't believe, the social workers, the dietitians, the physicians, and so forth, the parents always tend to believe. And that's what has always pushed us forward. But if everyone else doesn't believe, it's going to fail. And it's very easy to walk by and go, that baby's too premature, and walk away. It's to understand that caring for an infant born at 22 weeks is a constantly changing technological and medical challenge rather than a fixed immutable law of nature. Now, it was a fixed immutable law of nature in 1990. That's not any question. I remember having 23 and 5/7 twins just melt away because our surfactant was pretty primitive, ExoSurf, and we didn't have very good first intention high frequency. No one was giving these babies antenatal steroids, and we caused a lot of volume trauma, and you knew it was a biological threshold because you could ventilate, but you couldn't oxygenate. And the science is carbon dioxide diffuses 20 times more effectively through tissue than oxygen. So it was very easy for us to know, oh, you're at the biological threshold. And what happens, you can ventilate and not oxygenate, you crank pressures up, and then the baby dies. So that's changed with things such as antenatal steroids, number one, anti-volume trauma approaches, number two. They have the ability to have actually inhaled nitric oxide to help with pulmonary vascular resistance, number three, and certainly more effective surfactants. Number three is to realize that a large part of caring successfully for these infants is having a standardized multidisciplinary culture that supports a team approach to the care of these infants both medically and emotionally. You can't have the physicians, one night I'm doing jet, someone else is on, they're doing the oscillator. The next night someone's doing volume guaranteed. The next night someone's doing SIV pressure control, press forward. It falls apart. You can't do that. And so you have to have a standardized approach, not just initial ventilation, but to many parts of their course. The other thing is, even if things are going well and you have 6 to 7 out of 10 survive, well, what if you have those 3 out of 10 who don't survive in the same week? And we've had that before, and suddenly the nurses are emotionally devastated because it's hard dealing with babies that pass away. And you have to, and for me, I'm more robotic, and I'm like, what's the big, but I have to realize people have feelings, and you've got to be supportive and understand that. And so once we got better at supporting each other, we were able to get through these type of things. And I tell people, let's concentrate on the 10-year-old, the 14-year-old that comes back to visit, and you have to think more like oncology. The oncologists deal with horrible conditions where you may only have 10 or 15% survival, but the teams support each other and they focus on the cancer survivors, not so much the ones who don't make it. They don't such say, well, we're not going to offer chemotherapy or surgery or radiation anymore or biological agents to pancreatic cancer because survival's not high enough. No, they offer it. And they do it if the family wants to do it. If the family decides they don't want to do therapy, they don't. It's the family's decision, and that's sort of my philosophy with these babies. Which is number 4. Always respect and support the parent's preference to either initiate active treatment or choose comfort care. So this is a parental decision at Iowa. There's this falsehood that we force families to do this. We don't force them. It's families that pushed us 35 years ago to say, hey, how about thinking about, do everything you can at 24. And then soon they started saying, hey, how about everything you can do at 23? So we're caring for 24-weekers, and parents started saying, well, why can't you care for me if I'm born at a minute before midnight and I'm 23 and 6, but a minute after midnight you'll care for me, but a minute before you won't? And we're like, well, you're right, that's illogical. And so we started offering care to late 23-weekers, and they started doing well, and we started offering care earlier and earlier, and we finally got obstetricians to start giving steroids at 22 and 5/7, so we can optimize our care of 23-weekers. And that kind of went through all the 90s and the late 90s, and then somewhere around in 2008, my colleagues kept saying, we've seen 1 or 2 22-weekers survive. Parents are asking us, can't we offer steroids earlier? And I'm like, well, let me work with the OBs. And so we agreed back in 2008 to start offering steroids at 21 and 5/7 if that's what the parents wanted. And that's where those 79 babies have come from. So this was parents pushing it. There's this falsehood that it's Iowa pushing it. It's a mutually supportive teamwork with the obstetricians to begin treatment before birth with the use of antenatal steroids, even before 22 weeks. So we do 21 and 5/7. It's to realize that infants born at 22 weeks are not just smaller versions of infants born at 26 weeks and should be treated accordingly. Now, they are smaller, so you need access to 2OET tubes, but management of a 22-weeker is so different from a 26-weeker. When you apply standardized practices at 26 weeks to 22 weeks, you have very high mortality and morbidity. And you have to think very different about this population. We certainly wouldn't treat a 26-weeker like we would treat a 34-weeker, but people will treat a 22-weeker like a 26-weeker, and then it fails, and then they say, well, they're too premature. It's to recognize that the greatest error is not to have tried and failed, but then in trying we did not give it our best effort, and that's from the NASA space missions. And you think, well, we always give our best effort. That's not really true. When you have extremely premature babies, there's this inherent bias against extreme prematurity. And we all have it. It's been studied very well by Dr. Annie Janvier. And so it's just very easy to go, this is too hard, this is too much work, this baby's too premature. And I've thought that too sometimes. I remember it was a football weekend, and a former Vanderbilt person, Dr. McElroy, walked by because he's on his way to the football game, and we just got 23-week twins, and he's like, here's some extra tickets for you. I'm like, these babies are just born. You know, I'm going to be here for a long time. He says, oh, you know what you're doing. You'll get them stabilized before the fourth quarter, which did happen. But I did remember thinking, geez, if these only were 26-weekers, I could just walk out right now. Here's my ethics talk. To understand that 3 sorts of ethical concerns are generally raised about treatment of babies born so prematurely. One is that too many survivors will have severe neurocognitive impairment. Another is that parents do not watch such treatment. A third is that it costs too much. Evidence suggests that none of these concerns is valid, and that's a paper by John Lantos, who's an ethicist, and he published that in 2021. Okay, so when I think about, as a space nerd, when I think about caring for 22-week babies, I think it's like the moon mission that was over 50 years ago. We know landing on the moon was hard, difficult. Many people thought it was impossible, but it wasn't. And the key wasn't the 3 astronauts, Neil Armstrong and Michael Collins and Buzz Aldrin, but the hundreds of thousands of people that created this huge workforce to allow this to occur. The other thing I learned very recently, and that's why I have the picture of the Earth from the moon, is that there were numerous micro adjustments made in their trajectory so they wouldn't miss the moon. There was a lot of concern that they would miss the moon. It's hard having these objects 250,000 miles apart and hitting them, exactly. And I'm like, how did they do this? And then you find out, oh yeah, they make multiple course corrections. And to me, that's like a 22-weeker. The first 7 to 14 days of life, you've got to do multiple course corrections. Because if you don't do multiple course corrections every 3 to 6 hours, if not, even more frequently, and then you go off course, well, now you're dead from AKI, you're dead from PIE, you're dead from grade 4 IVH, and so forth and so forth. And so it reminds me of the moon mission. So the philosophy is we expect these infants to survive and thrive. We know it's hard and difficult, not impossible. The picture of the girl being held by her sister at age 5 was from the cover of the New York Times. This is there at 22 1/7, 488 grams, 49th percentile. She was at another center. They told mom they do nothing for 22-weekers. Mom caught our OBs at 22 and 0, and the OB said, oh yeah, just come on down, the NICU will take care of you. So they luckily got them to give a shot of steroids on the way down. The baby was born the next day. I was at that delivery, and the fellow did a good job intubating, and we didn't have to listen to the heart because you could see it clearly through the translucent chest wall. So it was very easy for me with bad hearing. I'm like, let's get to the NICU. And she flew through it. There's another little girl there, 22 and 2/7, 379 grams, 3rd percentile. She flew through this. Her mother was a great advocate, and I worked very well with her mom. And there were certain biases from the nurses. And mom is like, I can get her to feed if you could just let me go home, And I'm like, why don't you, if you could just spend a night, let me just see how feeding going. It goes well, and I sent her home, and she did great, obviously. And then the next one is the male. The male is always the trouble. 22/6, 465, severe pulmonary hyperplasia before 20 weeks. We could not get the heart rate above 100 in the delivery room until, well, actually, he was born in the hallway. I'm sorry. He was born in the hallway until one of the transplant nurses came by and said, have you transilluminated? I'm like, oh, yeah, that's a good idea. And she whipped out a pen light, and baby had a pneumo. So we needled, got a heart rate over 100, went back to the NICU. Now, he did have grade 3 IVH, no shunt, medical neck, no surgery. And I guess he is hardy farm stock because he's bottle feeding a calf there. But he's not, he did develop a chronic seizure disorder in junior high. And it was at the NICU. I don't know, maybe it was. So rates of active treatment account for 78% of between hospital variation survival in children born at 22 or 23 weeks. Because you have to offer active treatment or survival is 0. But rates of active treatment did not account for most of the variation for infants born at 24 to 26 weeks. For example, among hospitals that treat 100% of infants born at 24 weeks, rates of risk-adjusted survival varied from 42 to 70%. So management makes a huge difference. It's not a 1 or 2% difference. This was controlling for all types of variables that people say, that people want to blame for the differences in survival. Well, a lot of it is obviously management. So just the decision to resuscitate is important, but factors other than that contribute heavily to variation in outcomes. So the danger is just deciding to offer resuscitation at 22 to 23 weeks without adjusting management strategies is not the best approach for the care of these delicate patients. The entire country of England just published their paper on this, where they decided, let's just lower the threshold, and the outcomes were very bad because they did not tell anyone you've got to treat these babies differently when they drop to 22 weeks. One of the concerns is if we start offering care to 22 and 23, is the NICU going to be overwhelmed? And the data does not support that. So in 2019, there were 1,822 weekers, 2,623 weekers, 3,424 weekers in the US. You know, it's not going to overwhelm any one single state. Now, I have this twin here, 23 and 6/7 weeks. And this is important. This is demonstrating how we let the parents decide. His sister was born a week earlier, 22 and 6. Mom did not want to resuscitate, and we were fine. The baby had compassionate palliative care and passed away. And then she said, okay, when he's born, I want everything done. And so that's going through. He came to my retirement party, you know, and he wanted to remind me that he's a podcaster and I'm not. I'm like, okay, I don't even know what that means, but that's okay. This is sort of a peri-viable census back in 2019. There were 5 22-weekers that one day. 2 out of the 5 did die, so 40% death. 3 out of the 5 survived, 60% survival. This is one of the twins who survived. His twin did die of NEC, late NEC. And this is him at mountain climbing, and people are like, well, he's not above the tree line. I'm like, okay, just cut him a break. But you can sort of see he's on first intention jet there. He still's got his polyethylene plastic around him, and he was 29th percentile. This is a more recent one in 2021. And our 22-week survivor in 2021 was 7 out of 9, 78%. Now, what I'm throwing in here is a 21-week baby, 21 and 3/7, 410-gram male, 20th percentile. This baby is alive because his mom, who you see there, the mom comes in unexpectedly, goes to triage. The only one in there is a labor and delivery nurse, and the baby pops out. And mom looks at the nurse, says, can you get me help? Can someone help? So she hit the button. Our team is always willing. The team comes. The mom says, can you try? We're like, okay. And so he flew through, and this is the fellow who intubated him a year earlier. And so that created a lot of angst because people were saying, well, we heard we're not going to offer resuscitation at 21 weeks. And I said, we never said that. We said we would support the parents' decision. We can't really give them valid numbers on survival, but we would say either the baby will live or won't. And if the parents want us to try, we will. And if they don't, we won't. And most of the babies, if they don't make it, they pass away in a few hours. But it angered a lot of people. And eventually we calmed them all down. The main complaint was, well, you're not letting the mother hold her child. And I'm like, this child will be able to hold the mom in the future. Now, we have had, there's a list there of 3 21-weekers. He actually is old enough. We've done developmental testing, which is completely normal at age 2. There's 2 21-weekers there. No, granted, they're both 21 and 6. They're small, 305, 365. They're both home and normal. So I don't know. I'm just saying that I don't know what the threshold is anymore. I honestly just don't know. Other maternal characteristics that are important, you know, people think Iowa is all Scandinavian farm stock. That's our babies do well because they're born in a cornfield, they lasso a pig, and they ride out. And, you know, yeah, there are a lot of white, but, you know, it is 18% black, 2% Hispanic at 22 weeks. and at 23 and 24, 67, and 20%, 23%. But when I look at survival, I don't see any difference. There's no statistical difference. Black is 62%, white's 59%. Now sex, again, males are inferior, so survival is less. Males 56%, females 65%. Now, I'm not going to go to C-section just yet. I just want to talk about multiples. Why are you being born at 21 weeks? Multiples is incredibly high. 39% of our 22-weekers are multiples, including one set of triplets. And the multiples dropped to 24% at 23 weeks and down to 13% at 24. So obviously that's a major cause. The other one is chorioamnionitis. 30% clinical evidence of chorioamnionitis based on the OB assessment, but it's even higher. One of our R01 funded researchers, she's a big expert in immunology of extreme prematurity, so she's reviewing all the histology of the placentas, and it's like 60%, 70% of these babies have like necrotizing chorioamnionitis in the placentas. So a lot of it is due to infection leading to this. Now C-sections, we don't offer C-sections at 22 weeks. And you're like, well, I see a number there. What, So we don't do any monitoring at 22 weeks. We don't do any C-section for fetal distress at 22 because OBs have 2 patients, which is really hard. And you can see our C-section rate begins at 23 weeks, which is 44%, and then more aggressively, 71% at 24 weeks for fetal issues. Those 6 babies were sectioned because it was for maternal indications only. These were women who the pregnancy had to end to save their lives. They did not want high-dose cytotech inductions. They wanted a delivery to see their babies alive, and they wanted attempted resuscitation, and that all went well. Okay. Now, Sweden also does not offer any C-sections either at 22 weeks, and we're comfortable not offering for fetal distress, so is Sweden. But in the US, there's this falsehood, this myth that if you give antenatal steroids, you must do a C-section. There's no connection between those two, but some people think there is. And I was kind of shocked in that paper from 2018 that 32% of centers think there's a connection, so they start doing fetal monitoring and then do a C-section. One of the questions is, well, you can't have anyone alive less than 24 weeks because you don't have a VLI. Okay, well, things aren't. This graph shows the canalicular phase, goes to 24 weeks, and there's a perfect line, saccular phase, which you have to have gas exchange, just begins at 24. Well, everything is on a bell-shaped curve. So you have to obviously have a velar sacs, and the whole issue is the lungs don't mature at the exact moment you hit 24 and 0. So there are areas of the lung that are mature enough to support survival at 22 weeks because the cranial segments mature faster than the caudal segments. The key is you need to accelerate the lung development and minimize damage to the lung to have improved survival. So 1, you need antenatal steroids, and 2, you need a lung protective strategy. Now, why is that so important to have, accelerate lung development and have a lung protective strategy? Well, let's look at the cause of death for 22-weekers at Iowa due to respiratory failure compared to the rest of the US. So respiratory causes, and this is from the paper from 2022 by Sunny Jewell, would be RDS, late respiratory failure, and pulmonary hemorrhage. And at Iowa, first intention, high frequency ventilation, primarily now with the jet, respiratory causes are only responsible for 8% of the deaths for babies born at 22 weeks, versus in the preterm erythropoietin neuroprotection trial, that unfortunately didn't work, but the follow-up paper in 2022 looked at causes of death. And respiratory causes are responsible for 60% of all deaths at 24 weeks and 50% of all deaths at 25 weeks. So to me, that's shocking. When 24 and 25 weekers, the leading cause of death is respiratory failure, something is not right. And that's throughout the entire US. That's 19 US sites, 941 infants. If we look at respiratory outcomes, for our babies in this paper that was published in 2020, the median post-menstrual age at the time of extubation was 31 weeks post-menstrual age. A quarter were extubated before 29 weeks post-menstrual age. So you have to look at post-menstrual age. For these babies, you can't say, oh, they're on the vent, half of them were on the vent for like 63 days. It really matters where you are at post-menstrual age. And what you really want to look at is grade 3 BPD. That's what you want to focus on, which is Eric Jensen's work. And grade 3 BPD is what correlates with a 2-fold increase in neurodevelopmental impairment. And so our incidence of grade 3 BPD, which is stuck on a ventilator at 36 weeks, was 6% when we published that paper, 06 to 2015. More recently, it's gone to 9%. We get a lot more patients referred with rupture of membranes before 20 weeks. Now, how many 22 and 23 weekers are trached at Iowa? It was 3. Only 3 out of 195 22 and 23 weekers have ever been trached. Other outcomes, you know, it's not 100% morbidity in this population. So severe IVH for 22 weekers was 22%. PVL5 neck is higher than baseline. It's 11%. Our baseline neck for VLBWs is 1%. But of course, it's higher at 22 weeks, and we've been working on lowering it. ROP treatment for us is pretty low at 22 weeks, 11%. In Japan, it's like 60%. And everything's better at 23 weeks. Now, I'm showing some more twins. There's so many twins at 22 weeks and 23 weeks. And the 22-weeker, his brother did die of NEC. The 22 and 0 baby in the box, 440 grams, 18%. His brother died of a grade 4 IVH. And like I said, we will redirect care if that's what the parents want. So the question is, what about severe disability? And our rate of severe disability is 11%. So neurodevelopment impairment is just 11%. It's not 30%, it's not 50%, it's not 70%, it's not 100%. And we published that in 2020. Now, you know, it is higher at 22 weeks. It was 18% in that small cohort, and 23 was 9%, 4 to 5% at 24 and 25 weeks. And the important thing to realize, the 2-year study is the worst they're going to be. There's brilliant work by Genevieve Taylor published in 2021 in Pediatrics. She looked at these kids at age 10 and found almost 2/3 of the severe to actually profound shifted to normal to mild. So I hate when people tell me they're using calculators and counting the risk of neurodevelopment impairment at age 2 to make a decision whether they're going to offer a chance of life, when that's wrong by over 2/3. Certainly, some of these babies do need to go home on tube feeding. Now, some people have also asked me, well, what about VP shunts? I mean, how many VP shunts? I'm sure all these kids must have shunts. It's been, our incidence is 2%. So 4 out of 195 22, 23 weekers needed a VP shunt. Again, these are inborn babies. The key is maternal fetal medicine service. You've got to work with them. And we know antenatal steroids, paper in 2018 showed it doubled survival at 22 weeks, 18 to 39. And another paper recently in 2022, combining 22 and 23 weekers, survival improved by 50%. That's one of the key things at Iowa is that we use a lot of antenatal steroids. There's no reason not to get them. In 2021, 99% of our eligible patients, which is any VLBW patient, got steroids. And compared to the Vaughan NICU type C, which is 89%. Now, the nice thing is ACOG changed after getting more data. ACOG updated their recommendations in September 2021. And now at 22 and 0, it now says considered versus not recommended. Not recommended doesn't mean harmful. It just means there wasn't enough evidence in literature for them to put consider. And they only put recommended when there's large RCT. There's just not enough interest in anyone ever doing an RCT in 22 and 23 weekers because the mortality is so high at most places, and there's just not enough of them. So now there's, and consider means, well, as an OB, why should I subject the mom to steroids if the NICU's not going to resuscitate? So everyone has to be on board. All right, now, disclosure. I am not an MFM specialist. So these are slides I brought because people ask me some MFM questions. So here's our OB/GYN guidelines. You can see it, steroids are started at 22 and 5/7, latency antibiotics if appropriate, magnesium neuroprotection if contracting, tocolysis if needed for the 48 sterile window. Fetal heart rate monitoring, there is no EFM at 22/7. They check once a shift a handheld Doppler because if there's an IUFD, we don't want to go in and do an aggressive resuscitation. We do not do C-sections basically at 21 and 5. At 23 and 0, what really changes if the parents want to do a C-section, and then they'll start, more EFM monitoring. Like I said, antenatal corticosteroids at 21 and 5/7. Magnesium, we don't have a standardized regimen, so I don't know what dose they use, but they do start if full resuscitation is planned at 22. And the benefit is for babies born less than 32. There are no 22 and 23 weekers in any of these studies, but we feel it should be a benefit if it works for the 24 weekers. Latency antibiotics, they talk about it if you're 21 and 5 for preterm rupture of membranes. Tocolytics, again, if you're trying to get betamethasone administration, we do not use indomethacin for tocolytic because of the association with perforations. Electronic fetal monitoring, this is what stresses people out. We just do this daily fetal heart rate Doppler. We don't have any stress. You know, if we're happy, if the baby's born, at least it's had the steroids on board. It's very hard, I feel, to use electronic fetal monitoring to even determine when to do a C-section for a term baby. Because if we knew with enough precision, there would be no cooling. So if we don't know when to section a term baby based on monitoring, how can we do this for a 22-weeker? So diagnosis of fetal compromise by NST is limited given that parameters of EFM are based on the physiological responses of a fetus at or near term. So this is something, because the OBs have the hardest job in the world. I could never do it because I don't know how you balance two patients. I'm very black and white, and there's no way I could balance. My brain would just shut down trying to balance mom and baby. And it's much easier for me. Oh, the baby's born, I can do everything. With moms, if that's what mom wishes. If mom wishes everything is to hold the baby at birth, that's what we do. We don't do C-sections, like I said, at 22 weeks. The current research is very mixed. I would say a recent paper implies that outcomes better with C-section. That paper was based on a national database, and they could not adjust for antenatal steroids. So if people are doing C-sections at 22 weeks because of antenatal steroids, is it the C-section or is it the antenatal steroids that makes the difference? And I'm a strong believer it's the antenatal steroids. Some other things that have changed over time at Iowa, you know, only 7% of the babies go now without any antepartum exposure to steroids, so 93% get some steroids. In the past, 14% were never exposed to steroids. Meg sulfate for neuroprotection, 87% of babies between 26 and 6/7 get it. In the past, only 49% got it. And I know you guys are talking about delayed cord clamping. In our population, 22 to 26 and 6/7, it's now up to 57%. From 2010 to 2017, it was only 17%. All of those things greatly improve neurodevelopment outcome because all of those reduce IVH. So survival at 22 to 23 weeks is extremely difficult, but not impossible, not hopeless. And you can see, mom sent me the 22-week twin girls at age 5. One of the important things to realize, one of them is alive because we listened to the nurse practitioner. I remember it was Saturday morning on rounds, and she starts telling me the glucose was normal but lower than expected. And I'm like, I was about to say something idiotic, like who cares? Luckily, I kept my mouth closed. And she said, you know, if the glucose level changes and nothing else has changed, that could be a sign of early sepsis. So I sent off CBC, CRP, worked the baby up, started antibiotics, and the blood culture came back positive for E. coli in less than 12 hours. There was a 30% left shift and already an elevated CRP. So rather than waiting till the baby was hypotensive and tachycardic and poorly perfused, she acted on a subtle finding, and that's why that baby is alive. And that baby probably was one of the things, baby probably was born with E. coli but latency antibiotics, it's rare you get a positive blood culture. And so we did give 7 days, and this baby got sick 3 days afterwards. So the key is really listening to the bedside, whether it's the nurse saying something subtle with tachycardia. We've had other babies that the mom has saved their lives because the mom says, the baby just doesn't look right. And if mom says the baby doesn't look right, you're obliged to go examine that baby. And usually what I have to say is, get off the computer, go to the bedside, do hand hygiene, and examine your patient. And it's really hard to get people out of the workrooms to do that and actually listen to the nurses because they will tell you what's going on. And don't go in there with a closed mind. Sometimes the staff have the most closed mind. And so another time we've had moms say the baby doesn't look right. And those babies, if you work them up, they often had positive blood culture. And it's, like I said, it's very easy to know when someone's in septic shock when they have no blood pressure, but it's too late. Now, some brief long-term follow-up. So people complain, well, what do the 22-weekers do in college? I don't know. They're not old enough yet. They will be in 2026, so I'll let you know. But this is a 23 and 2/7 weeker, had Candida sepsis, got 6 weeks of amphotericin. She graduated high school, is attending college. But the interesting thing was the parents are very stressed because it took a long time to figure out her learning disability was she could not add, subtract, multiply, or divide. Once they figured that out and the school let her use a simple calculator, she passed AP Calculus. Now, I didn't pass AP Calculus, which irritates me, but my teachers were on strike for 6 weeks. So I blame my 6 weeks at the beach as the reason I didn't pass. Now, this is another baby. This is one of our BPD outcomes. This is a 24 and 0.7 weeker. Was on first intention high frequency. That was the infant star a long time ago. She anchored a 4x100 meter relay, Division III national champion. And people are like, well, it wasn't Division I. I'm like, yeah, let's see you run 100 meters in less than 11 seconds. She graduated college, and I was lucky. I went to her wedding this summer. Now, she was 29 years and 10 months, but just for prematurity, that's 29 years and 6 months for the wedding. Okay, so thank you.